So the first speaker is Dr. Paul Babyn. He's a radiologist in chief in Toronto at the Hospital for Sick Children. And one thing I find really interesting about Dr. Babyn is he got his MD from McGill, but his first degrees are in electrical engineering and biology from MIT. So he knows, certainly he's encountered mathematics and encountered signal processing and these sorts of things. So I thought he'd be a very appropriate speaker to go first. He's contributed over 100 publications so far in his career. His research is in musculoskeletal radiology and cross-sectional imaging. And with that, I'd like to introduce Dr. Paul Babyn to speak about a critical overview of the state of medical imaging, what's working and what's not. So we can try with the two mics. But would we expect the same interference happening with everybody? Okay. So it's up to you. If you think you can talk loud enough, you don't have to use this one.
So hopefully I won't have the quite the same heartbeat as Jeff. But thanks very much, Jeff, for the invitation. When Jeff came to talk to me about this conference, I really didn't have a very good idea of what he was hoping to achieve. After I put my talk together, I think I have a much better idea of what he's hoping to achieve. So the next version of this talk will be much improved. But just to start off, I wanted to illustrate for you how medical imaging is being used today in large part, and how image processing plays a role in medical imaging, which oftentimes we think is probably much more than it is actually occurring in the clinical practice, and much less than is capable in the research environment so far. So with that, let's go. So today I'd like to divide the talk into three sections. One is to overview medical imaging, the goals so that we keep in mind what we're trying to achieve, the acquisition modalities that are commonly used in a modern hospital environment, and the changing practice pattern that we're seeing in medical imaging today. And I don't know, Jeff, if you have a pointer by any chance, a laser pointer. Second, we'll look at how image processing is used today and cover some of the uses from... Thank you. Okay, that's very fancy. This one. Okay, stop. Leave that one. Okay. So we use how image processing is today from data acquisition through some examples in surgical navigation. And then I'll just put in some areas that I think medical imaging needs improvement, some of which are already underway in the research laboratory, and others are still not as yet being addressed. I thought I'd start off by just, as we're being propelled through the digital age, with the quote of Will Gibson, that the future is already here, it's just not evenly distributed. So I think that there's many great ideas that we're going to hear today and during the course of this meeting that people are working on that will have great impact in what we're doing in imaging. Now, medical imaging is really medicine's inner vision. And it's not surprising how often clinicians will come down to the imaging department before they've actually seen the patient and referral to try and get a true sense of what's going on, and then they can better assess the child or patient. There's been, of course, tremendous growth and development in the environment over the last 110 years since Röntgen's discovery of the X-ray, with about 35 million medical imaging studies being performed each year in Canada. And that would cover the full breadth of imaging studies, from conventional X-rays, which are still sometimes obtained on film, through the very advanced medical imaging studies that we have available. As Jeff mentioned, medical imaging is a very information-rich specialty, with our storage requirements per year just in our institution alone at approximately 3 terabytes of information. And we have our own dedicated IS systems group within our department, and we try and make sure that the gorilla of medical imaging doesn't overwhelm the rest of the hospital's network. This is just an example here of some archaic equipment from 1917 available at the Hospital for Sick Children. Now, you can see here illustrated some of the dramatic changes that have occurred with the introduction of digital technology over the last roughly a quarter century. The first image depicts a CT scan obtained in 1975. A total time for acquisition would have been well into the minutes, tens of minutes, versus the current sagittal reconstruction that we have here of the brain, which would have been obtained in less than 5 seconds. So there's been, with each generation of equipment, markedly improved resolution, image quality, and speed. That also, though, has led to, as each generation is being replaced in a differential rate within institutions, a very variable amount of equipment and capability within institutions in terms of what they can offer. Now, I thought we'd spend a minute discussing the goals of medical imaging. And there's really twofold goals of medical imaging. First is to provide accurate and timely diagnosis of disease and anomalies. Our goal is to evaluate the progression or regression of disease and its response to therapy. Oftentimes, a child with cancer, for example, will have 40 to 50 CT examinations in the course of their treatment. So it's very important that we have full ability to handle that type of data. The second aspect of medical imaging, and this is a growing role for medical imaging, is to provide image guidance during a performance of interventional procedures. And these procedures are minimally invasive procedures that may obviate the need for surgery and reduce the risk and harm to the patient. It's important to spend a minute saying that it's really a systems approach that we need to consider. So excellence in image acquisition is a very integral part of what we're trying to achieve, but as well we need excellence in the image interpretation, which is provided through the human eye and visual system, as well as the cognitive process of the radiologist. And I can assure you it's quite different at 8 o'clock in the morning and 5 o'clock on a Friday afternoon. So it's very important that we keep the system aspect in mind, and we want to make sure that we minimize the cost and the potential complications that are occurring to patients, as well as the radiation use and contrast use. Now, today's radiology department, for those that aren't familiar with it through personal exposure, includes a variety of complex computer systems. We have two main aspects, which are the picture archiving and communication system, which deals with the image acquisition through image display and analysis, as well as an accessory radiology information system, which predominantly deals with the information, textual information aspect of the department through the reports and accounting, etc. All of these, of course, are connected together for image display workstations. We may have separate image processing workstations, which are in, again, current generations, which will vary throughout institutions. The work environment is one where there is a need to provide information very quickly. Both patients and physicians are waiting for our results. The treatment is often changed by our findings, and there's a high cost of error. So you need to keep in mind that missing a lesion can have severe consequences, while overdiagnosing a lesion can also have severe consequences if it leads to unnecessary treatment or surgery. Now, the imaging modalities that we use in an X-ray department are listed here, with the last one being a special case for our hospital at the moment. So generally you have imaging modalities that are X-ray dependent. So we have projection imaging, which is the conventional film screen radiography, or computed radiography, or digital radiography now. We have digital fluoroscopy and angiography. X-ray use is, of course, in CT. And these are all sensitive to tissue density as well as atomic composition. We have other imaging modalities that provide functional information from a variety of sources. So these are predominantly nuclear medicine imaging related. They are PET scans or positron emitting tomography. They depend on injection of a radiopharmaceutical, which is taken up through various biochemical pathways in the patient, and then the imaging is dependent on the distribution of that radiopharmaceutical. Magnetic resonance, and I know we're going to be hearing a lot more about magnetic resonance throughout the conference, is one of those specialties that's really in the dramatic up phase in its development. There's tremendous information that's provided by MR, both functional and anatomic information, with a multitude of contrast mechanisms available to distinguish normal and abnormal tissue. And these mechanisms can include proton density, as well as T1 and T2 relaxation time, and many other factors. Ultrasound is very important in the pediatric environment, less so in our obese adult population, but clearly provides a lot of information through reflected sound. And magnetoencephalography looks at the magnetic fields that are generated by the brain. So if you look at the imaging modalities, they have a variable distribution in temporal resolution, spatial resolution, types of information that they are demonstrating, artifacts, as well as many other problems and differences between the types of imaging modalities. For example, a child may undergo an MR, but often will require a general anesthetic or sedation, but this won't be required for a CT. However, children are much more susceptible to radiation than adults, so undergoing a CT is more problematic, and these are some of the concerns that we're faced with in daily practice. Now, the basics of medical imaging, and probably everyone here is more familiar with it than I even. We still have analog images in a variety of situations for a conventional film screen, but much more commonly digital, particularly in those institutions that have incorporated PACS systems into their medical imaging departments. The two-dimensional images, just so that you know some of the nomenclature, consists of a matrix of pixels or picture elements, while three-dimensional, the matrices or volume elements are called voxels. And you can see listed some of the typical matrix sizes that are available from the imaging modalities. They do differ amongst them in terms of the information content. You can see that computed radiography has a many larger size per image. CT and MR will, of course, have many more images than a typical CR study. Now, a lot of radiology has been directed to morphologic imaging. And morphologic I define as anatomic depiction of the information. So within the information, the radiologist is looking at the images, trying to determine normal or abnormal, and if abnormal, what the abnormality is. So for example, in this child with a large tumor in the nasopharyngeal region, or the region behind the nose, You can see depicted how we will look at the study on a coronal section, a sagittal section. This is a T1 weighted image. This is a T2 weighted image. So we're depicting the information in many different ways, even though it's the same anatomic area. And what we're trying to do is more accurately determine the volume of the tumor, its extent, and the type of abnormality that it is. We can administer contrast materials, which are agents that help to differentiate abnormal tissue from normal tissue. And in this case, with the administration of contrast, we can see a marked increase in the signal intensity of the lesion in through here. We can also use the contrast administration to demonstrate the vascular supply within the brain and how it's affected by the tumor, as shown on the right there. Now, with our contrast administration and detail, in some patients we can get tremendously fantastic images from our perspective. This is images of the coronary arteries that were obtained in the heart with an MR, and you can see the tremendous detail that's now available in the beating heart. So this is what Jeff's heart would have looked like as we heard the beating earlier today. Now, you have to keep in mind that medical images are not all the same. There's a lot of variables that we need to consider. So we have different contrast mechanisms, as I've tried to illustrate. We have variable equipment. We have variable techniques for acquisition. So one radiologist may prefer a protocol for examination that differs from another. The slices are going to be quite different. There's going to be different artifacts seen on the images. We're going to try and minimize our dose, which may depress the signal to noise. So there's a lot of variations as well as the variation within human data. Here, for example, we can see some of the artifact on MR from pacing wires, which demonstrate extensive drop in signal. And if you're interested in this area, you can't be distracted by the abnormality of the artifacts in through here. Okay, so we've seen that there's a tremendous increase in imaging modality capabilities. Over the last quarter century, we have image reconstruction improvements, so the computers can now process the images very quickly. We can now acquire the images very quickly. And indeed, in a lot of cases, particularly with multidetector CT, we can have volumetric coverage and isotropic voxels. And this has led to the growth of new areas of examination. So we have screening examinations with whole body CT are now being offered. We have screening examinations with whole body MR. And this generates a tremendous amount of data that anyone who's had a look at the visible human data sets can well imagine how extensive that information is. As well, we can extend our examinations in time. So we can administer contrast material and look at MR urography, so we can follow the passage of contrast through the vascular system, through the kidneys, into the collecting systems of the kidney and down into the bladder over time, or we can do temporally resolved angiography. Here, for example, is some, just to illustrate the type of detail that can be obtained with a volumetric MR examination. This whole volume can be collected very rapidly, every 4 to 6 seconds, or even faster, and you can get an excellent depiction of the vascular system of the heart, pulmonary arteries, and veins. Now, I'm sure that a lot of you in the room are aware that there's been tremendous progress in medicine in general, and medical imaging is forced to keep up with that and indeed trying to help demonstrate some of the changes. And there is a change in growth of imaging from anatomic depiction now to try and better demonstrate the underlying biology of the patient. So we can now look at, for example, some abnormalities in perfusion, abnormalities in diffusion, and with our nuclear medicine and other techniques, look at metabolic abnormalities in the patient. These imaging modalities try and provide physiologic information, biochemical or structural information, and they're often abnormal or may be normal when the anatomic imaging is still normal. MR in particular has shown a lot of growth in this area with the functional imaging of the brain, biochemical information from spectroscopy, as well as other types of imaging has grown significantly. Another important aspect that has grown is our ability to quantify the information and provide that information to our physician. So here's an example where on the anatomic imaging, the MR, a slice of the brain, there's only very subtle abnormality. And if you weren't a trained pediatric neuroradiologist, you could easily overlook the abnormality in this child who has an underlying metabolic disorder. MR spectroscopy was attained, which shows a very large abnormal peak. And that is the tip-off that there's a disorder here that the radiologist should have a clue in. Spectroscopic imaging, so we're taking the anatomic information, overlaying on top of that spectroscopic information with multiple area voxels and getting the same spectra that we were looking at before throughout the brain now. And now we're dealing with a much more complex informational display. We have the ability to look at each particular peak and display that on the anatomic imaging as we were doing before, and we can do that for a variety of peaks. We're turning now to functional imaging, which is a non-invasive tool in the study of brain function. We can look at sensory, motor, or cognitive function. You can do this with MR or with magnetoencephalography. With MR, special sequences used to demonstrate alterations in blood flow to the brain. Active parts of the brain utilize more oxygen and receive more blood flow than less active areas. And then the data is superimposed onto more detailed MR images. And here you can just see the changes in signal are dependent on the change in flow of the blood and its components, so that with activated states you get increased MR signal. Now with MR, and this is a picture of the with the MEG. This is a picture of the MEG suite at the Hospital for Sick Children. It's also a non-invasive test, but instead of looking at an indirect measure, which is the blood flow, it measures the magnetic fields produced by the brain activity directly, and then the images are superimposed onto MR images, and this is known as magnetic source imaging. The magnetic field generation is by the axons and is very similar to the magnetic field through the current. And here you can see the schematic of the machine itself, a very large dewar with liquid helium, multiple sensors, squid sensors in through here, and you can see that it's many orders of magnitude less than Earth's magnetic field that we're trying to depict. This is just a demonstration of the data that's obtained from each of the channels, and then they can be creating maps in through the magnetic maps as shown here. Quantification is another area where there's been tremendous growth, and there will be increasing growth over the next few years. Increasingly important aspect of care as we understand why some surgeries fail with the same surgery in patients. However, there's little enthusiasm in the radiologic community for application of quantification, probably because there's been a lack of standardization even for simple measurements. So you'll find that two radiologists will measure tumors quite differently. There's no standardization on how to measure tumor areas, no standardization how to measure tumor volumes, and no consensus really of how to display quantification with the images. It's already a significant aspect in cardiac evaluation at our institution. Here you can see some selected MR images through pulmonary arteries in a child following a complex congenital heart repair, about to undergo another procedure. And you can see the anatomic images that were obtained following the procedure, and it's very unclear as to why the child seemed to be worse after the surgery than before the surgery. However, when we look at the data that was obtained looking at the volume of flow within the pulmonary arteries, we can see before surgery that the right pulmonary artery had increased flow over the cardiac cycle compared to the left. But following surgery, there was a marked change, with the left showing even a more diminished function and even retrograde flow compared to the normal direction of flow. So quantification is going to be increasingly important, and we're going to need to be able to apply that information. Now, I'm sure that many of you, or probably all of you, don't need a definition of medical image processing, but I thought I'd include one that I thought was quite nice, that talked about the manipulation and analysis and the enhancement and illumination of information within the data stream. We have to remember that this can be both automatic or interactive under human control. Image processing is used throughout the data stream at the moment, but in very limited areas in some aspects of medical imaging, and with greater involvement in others. It's used at data acquisition, through the transmission of information, which may involve compression, as well as the visualization, and a growing component is the analysis of the information. We can look at the growing role for image segmentation, registration, navigation, and image analysis, and a lot of these topics are going to be discussed in greater detail with some of the later speakers. We have specialized evaluation, as I showed with some of the dynamic contrast enhancement, but we also have a growing role for computer-aided detection and diagnosis. If you look at how image processing is used today with the various imaging modalities, you can see listed here some of the typical varieties of how image processing is used. And this excludes a lot of the pre-processing that's used in the data acquisition. So we have the windowing and leveling that are used for the display. We have, if you just take, for example, under subtraction angiography, we have subtraction of images out of a sequence, temporal averaging, trying to enhance the image. So we have a lot of the sort of standard, simple image processing techniques being applied to medical imaging. When you look at image processing at acquisition, generally it's a black box in the way it's perceived, because the medical imaging vendors, they have a very proprietary nature for this information. Information is processed and provided to you, and you're not really aware of the steps that the information has gone through, what they've done for noise removal, what they've done for contrast and feature enhancement. Of course, having the digital information opens up new avenues for exploration. Some of these that have been thought about recently are dual energy subtraction. So you'll take an image for conventional X-ray is done at one particular energy level. With a digital X-ray, you may do it at two different levels and subtract, trying to enhance the difference and get a better sense of tissue characterization. You can do that with temporal subtraction. So being digital information, of course, allows us to now look at the information at different time periods, or subdivide the acquisition with tomosynthesis. Here's an example from MR, surface intensity correction, showing some of the capabilities of the system, and also some of the difficulties that still remain. With MR, the acquisition using surface coils may create problems in the image display. And you can see the shading that's noted here, and it may obscure pathology in a particular area depending on how the image is viewed. Here you can see, after the application of a surface intensity correction protocol, that we have some improvement in the image display, but it's not quite uniform throughout. Similarly, for contrast, for enhancement and computed radiography, this is an example. The conventional film screen had one type of display which accentuated contrast, and with the introduction of computed radiography, we get a wider latitude display, which sort of flattens the appearance and makes it more difficult to visualize. So you can see here we don't have a great contrast on this image between the bone and the soft tissues. With the application of, in this case, this proprietary multi-scale image contrast amplification from AGFA, we can see enhancement in the bone soft tissue contrast on the initial application, and then subsequently enhancement within the soft tissues in through here of soft tissue contrast, allowing us to see the full range of detail on one display of the availability of the information. Now, when you talk to a radiologist, the image processing, what they'll tell you is really just visualization of the data. That's the one that most people are familiar with. Originally displayed in static form on film, now we have the option of displaying it on a dynamic system with the PACS system, soft copy viewing, and we'll often have very dedicated processing workstations. And of course we have a multitude of tools, of fairly simple tools that are available on the PACS workstation for us. The introduction of multi-slice CT has really been, although it's the bread and butter for radiology, it's also been a very detrimental in terms of the number of slices and information overload that we need to address. We can do axial examinations now through neck, chest, abdomen, and pelvis in about 15 seconds. So the scanner always looks empty when the administrators are walking by. But then we have over 1,000 images to visualize, because we can obtain them at millimeter or even sub-millimeter resolution. So we need to come up with ways to display our information better and get the information out of the images in a better fashion. 3D reconstruction techniques allow condensed representation of the relevant information. A variety of formats have been proposed and are in use. Multiplanar reformat, maximal intensity projection, minimal intensity projection, ray-sum, and I'll show some examples of how we do that on the same data set. It's important to keep in mind that the actual application will depend on the task that's required and the viewer. So the radiologist may be much more familiar with looking at images in 2 dimensions and prefer looking at coronal reformats. The surgeon may be much more familiar with looking at information in 3 dimensions and prefer looking at information in the 3D perspective. 2 basic classes of volume visualization are in use today: surface extraction algorithm, volume rendering. And some of these may overcome some of the perceptive issues of structure that we need to consider. So looking at the same axial image, which was of a tumor in a child in the pelvis, it's very easy to see how we can display the information in coronal fashion through here, or sagittal fashion. And now we can much more easily distinguish abnormality within the bladder, the tumor lying on top of the bladder, displacement of the pelvic organs, much more quickly than we would be able to do with going through thousands of images in the axial plane.
Just pause for a minute and ask you to move your mic to the side.
Okay, sorry. Now we can do the same thing in the chest. This is an example of a multiplanar reformat in the chest, which is being done along a vascular structure, in this case the great vessel from the heart, the aorta. And what we're hoping to do is just accentuate the visualization along that vessel so that we can see it in its entirety. The maximal intensity display, taking that same chest data and just looking at it in a different fashion, can generate this image in through here. And you can see the quite variable difference in appearance. Here we have a reformatted image which highlights the pixel along a ray of the highest signal intensity as shown through the viewer and projected on a 2-dimensional screen. It doesn't allow us any quantification of image analysis, but does give a very good detail for the bones. We do have some contrast coming in through here, which is difficult on this image without rotating it to get a sense of its orientation in a three-dimensional space. We can take the same data, we can summarize it using the entire summary and display a ray sum, which is very similar to a chest x-ray. There's very little use for this once you have the CT, but that's some of the variable appearance in visualization that we can do. Surface shaded display, another way of looking at the information. It requires segmentation, first of all. So you have an object. You want to separate an object from the rest of the information. It requires the oftentimes manual segmentation to assure that you have the entirety of the object included or excluded. It can be done on the basis of threshold or texture, but only surface information is displayed. Here's an example, again, of the same chest data. What we would look at, here we're separating the heart from the lungs. You can see the surface indentation of the lung parenchyma, but you actually have no information of any of the details within the lung parenchyma. Are they normal or abnormal in this type of display? It's very useful for some anatomic depictions that we currently use. Here we can separate out the airway, so if we're looking for airway compression or deformity, we can do that with this type of display. Notice the artifact that we have through here. The trachea is not cut, but it's just an artifact from motion that the child did at the time. Another way to display the information is volume rendering, where we're not throwing away the data from the internal aspect of the volume, but displaying it in a different fashion. This has only been available in the last few years as the computer processing capabilities have become more capable, and it does require tissues that can be differentiated either by threshold or other criteria. And this is, again, an example of the same data displayed in a different fashion, showing the different information content, and that we do have the internal information still visible to us, but now we have superimposed for the radiologist an obscuration by the color, and trying to determine normal and abnormal when we're used to more black and white images is a little more problematic. Virtual environments are being created, particularly for endoscopy. This is being used for virtual bronchoscopy, virtual colonography, and angioscopy. And I can assure you that if you've undergone bronchoscopy or colonoscopy, the virtual version is much preferred. Now, again, this requires us to have different ways of looking at the data, different ways of displaying the information. We have a tremendous amount of information, and this is just an overview of a dedicated workstation looking at CT colonography, so a virtual colonography. So we have information here. You can see that air has been placed into the colon, distending the bowel, and we can follow the tract as we examine the colon and through here. You can mark on various areas of abnormality. You can display the information in multiple planes, in different projections. These are Mercator projections, and through here, colorized to try and show shading and highlight areas of depression or elevation of the bowel itself. All of these techniques really are not done automatically. They're done when you know there's an abnormality or suspect an abnormality is there, so you'll pay particular effort and time into doing that. And they often require specialized expertise. So a large number of the larger departments will often have a very dedicated individual, a 3D technologist who will actually perform all the 3D examinations because the capabilities of the radiologists are limited in this regard, and they will perform the examinations. Now, image registration. Another growing area for image processing in medical imaging. It's a temporal registration often used to following contrast examination or projection of one piece of information on another. We've seen some examples. It could be the same imaging modality, or it could be different imaging modalities as well. It could be the same subject or different subjects. A large number of databases are being constructed for example, functional brain mapping, where you're comparing the processing that occurs within one individual and a set of other individuals or normal population. PET-CT is the one that you may be familiar with. We still don't have that as a clinical tool in Ontario, surprising to say, but that's the reality. You can fuse information acquired from PET with CT. This was the Society of Nuclear Medicine image of 2005. And this demonstrates the fusion of PET information with the demonstrating increased glucose utilization in this portion of the body here and here. This is a individual with lung cancer within the right lung and a metastasis to a lymph node here in the lung. You can see again that we've presented the lung data in quite a different fashion to highlight the air structures within the trachea and lungs in this situation. Of course, PET information can be fused with MR, not just CT. And in this patient, we can see altered activity within one side of the brain cortex here. Even though structurally and anatomically we don't depict any abnormality, we can see there's a clear functional abnormality with a diminished PET uptake in that area. Similarly, with the MEG, the localization of the dipole can be projected onto a 3D MR and give us a magnetic source imaging information. And some of the work that's done at Sick Kids here is now applying this to functional information. And you can see the temporal resolution here being counted down in milliseconds as this individual is tapping their finger repeatedly, and we can see activation in initially within the motor cortex and then subsequently within the somatosensory system, more in a different location, superimposed on 3D MR. Turning our attention just a little bit to the interventional aspects of medical imaging. Here you can see how most interventional work is done. The integration and image registration and alignment is done in the radiologist's brain. We have this young infant undergoing a procedure. They're utilizing ultrasound in this case to try and guide the techniques that they're using. Of course, surgical navigation is a growing part of multiple image multiple subspecialties, particularly neurosurgery as well as orthopedics, where there is the acquisition of image information ahead of the surgery, which can be used in concordance with surgical placement and holders to get the information of the operating room environment and the patient's 3D onto one visualization technique. Here you can see an example of a system that we've recently acquired at the hospital. And this demonstrates the registration that can be done using some specialized regions. Either you localize over the face or fiducial markers. The patient is placed in a frameless stereotaxic area, and we can then localize the information that's obtained ahead of time from MR examination, as in this case for abnormality within the brain, and localize that in multiple projections for the surgeon so that he can choose which way he would like to enter the brain or how to display the information and see exactly where his surgical instruments are located at that time. Of course, it's very difficult during surgery to maintain the actual same environment as during the MR, but that's the state of the technology at the moment in most locations. This is just another example showing that we can localize also the epilepsy information preoperatively so that they can help identify appropriate regions of the brain for resection. So we've gone through quite a bit of detail about image modalities, and now I think we can go through some of the problems in the last few minutes. There's a lot of growth of capabilities, as I mentioned. These images are creating problems for the radiologists, and oftentimes they're problems that are compounded because the computer techniques that we have available haven't kept up with the generations that are currently seen. So for example, if we're looking at a CT scan, we have to look at CT scan soft tissue windows, bone windows, lung windows, all different sets of data which has to be sent to the workstation separately. So the PACS system, in one way, it allows us to do a lot of additional capabilities which we didn't have before, but at the same time it's a constraint for us and something that needs to be considered. So we need to have improved workstation display to handle multiple multimodality imaging display, as well as to offer a richer set of image processing tools. At acquisition, we've looked at a lot of simple applications. There's many more image reconstruction algorithms that are being proposed for the fully digital modalities such as CT and increasingly for MR. So parallel imaging and MR, multidetector CT, a lot of techniques are being developed for that. Digital radiography, we just started to utilize some of the information that's available on the film and figure out ways that we can better benefit the patient by reducing the dose, for example, with the application of a contrast filter, which we couldn't do really with a conventional film screen because it would have changed the appearance of the image too much, but we can adjust for that now with imaging, with digital techniques. New filter algorithms can be applied. Here, for example, is this Pixon technique, which is developed in the astrophysics world. Shows some comparison here with some of the other standard techniques that are available. When you look at the application to nuclear medicine, you can see here, looking at a count of 0.2 million, the difference between the current technology versus the Pixon process and how that differs as we increase our signal to noise. So there's a lot of techniques that can be applied at multiple areas throughout the system. This is just showing some preliminary work within the nuclear medicine of a patient, a bone scan, showing the conventional scan, which would take 2 minutes to acquire the 6 million counts versus the Pixon image in roughly a quarter of the time. Now, improved segmentation. I mean, the difficulty when you look at this is how to best display the information that's obtained. Is it better displayed anatomically because that's the way the radiologist is thinking? Is it better displayed in some other fashion? And we don't have the answers for that. What we do need to know, though, is we need a standardized approach that's going to be optimized for the radiologist. If the radiologist is going to do the interpretation, then we need to include him within the system evaluation. Here, for example, is a chest X-ray, and it's very easy to see the abnormality when you have a circle around it. It's a lot harder when you don't have the arrow yet. And that's because there's a lot of structural information from what we're trying to see here, which may be a lung nodule in this case. In other cases, we may be trying to see the cardiac configuration, and we don't care about the lungs. With CT, we can remove some of that structural noise that we have and display images a little bit differently. Here we can see the lung nodule on a CT scan, but now we have a lot more data to search to try and differentiate that. So it's problematic. We can display the CT information in this fashion, where you just display the lung parenchyma, and it makes the nodule detection perhaps easier. Nobody's really looked at that from this perspective yet, but certainly it allows the opportunity for computer-aided detection and other techniques, which I'll talk about a little bit later. So for image visualization, I showed you many different ways that we're using the information, displaying it currently. Standardization is going to be critical to reduce errors, to make sure that we've looked at all the information as the number of slices increases. We're going to need to have better integration with the multiple modalities and better integration with surgical equipment. And I'll just show you some of the difficulties that I'm seeing now as we start to get more data and more ways of displaying it. So here we have multispectral analysis. So what we're doing is taking information from various types of MR sequences, superimposing them, analyzing them, using cluster analysis in through here. The difficulty is, for the radiologist perspective, what does this color really mean? And why is there not red here when we see red here? From looking at the anatomic information, we have to recognize that we're going to have some ground truth in through here and use the image processing techniques a little bit differently and have standardized ways to display normal versus abnormal. Again, two different color maps illustrating some of the changes that you can see on MR. When you administer contrast, you can look at blood volume, permeability. The problem is, though, in the information display. I mean, here we've superimposed the information on anatomic images, but for a radiologist to have a sense of what this really means and how this color display differs between the two is problematic. So when we look now, computer-aided detection. And many abnormalities are already displayed on the information. So we don't need a tremendous new developments in our imaging technology. We need tremendous developments in our radiologist capability. And this is an area still in its infancy. Processing is applied to optimize detection. And many areas have started to be explored with this, including modalities such as CT or MR, as well as evaluation of breast and particularly lung abnormalities. So it's important to keep in mind that the computer detection doesn't need to be better than the humans, but the combination should be better. So what we're looking for, again, is the system. The combination between the human and the machine should be better than the human alone. And we want to reduce the errors from oversight and reduce variation between experienced and lesser experienced observers. Here you can see just a schematic of computerized analysis of breast images. This is work that's being done at University of Chicago at the Kurt Rossman laboratories. And it really is at the forefront for computer-aided detection. They've commercialized several of their systems. It's fairly complex processing and sequential evaluation of images to try and provide this to the radiologist, which is an image with marks that say this is suspicious to the computer for a mass, this is suspicious area for calcification. Did you see these? Will it benefit the radiologist? And they've shown the second reading by having two radiologists improves your accuracy. Second reading by having this computerized systems improves your accuracy as well. Of course, you can also use the computer to help you with your differential diagnosis. And here we're going to need very specific tools for having images that are either in the same anatomic area and tools that allow us to say this is an abnormality that occurs within this area, or this is an abnormality with a very similar appearance, and you need a very large database for that tools. And for example, we have a database at our hospital which has collected pediatric information over 6 years now, but we have no tools to really utilize that information in its aggregate. This is the display of how it can be used, a quote-unquote intelligent workstation. Although for a radiologist this is still going to be very busy, but it provides a different level of information content. And again, from Mary Ellen Geiger at University of Chicago, you can see a display of the information, cases that are from the reference library of very similar appearance and what the pathologic outcome was, the prediction by the computer of whether it's benign or malignant, associated tests that may be available, etc. A lot of what we do at radiologists is change detection, so we have a set of examinations from yesterday and we want to compare it to today's. Of course, it's very difficult in some regards to deal with that information when it comes from a different generation of equipment or versus today's equipment, and we need to deal with a lot of extraneous effects. But some of these things are starting to come into the research environment. Even just having simple image alignment so that we know this is the same anatomic level as the last examination where the abnormality is, without having to scroll through and adjust manually, would be a very big help for us. This is an example here of a child with a brain tumor. So this is pre-treatment. This is following chemotherapy. And you can see the tremendous changes that occur related to chemotherapy. And the question is, how's the brain tumor doing? And you have to take into effect all the miscellaneous abnormalities that are occurring elsewhere from other medical treatment that really interact with the image display and appearance. So we have large databases. We need to exploit these databases. We need to develop databases of normal anatomy, normal variants, and correlate with our pathology. There's no integration. There's separate silos between the medical imaging in the radiology department and the medical imaging in the pathology department, and those things need to be considered. We also have training issues. We have a lot of subspecialists in various areas in radiology, but we also have a lot of general radiologists that are asked to perform at the same level as the subspecialist when they look at a case of a child or a neonate versus an adult. And so there's a lot of training issues that need to be overcome, and hopefully we can do that in the years ahead. So in conclusion, digital images now offer very improved quality. Computer capability is there for most of the analysis that we want to do. I'm certain that image processing is going to be a key and integral aspect of most imaging studies in the years ahead, and increasing role from image analysis. And we need to ensure that the tools are optimized for the radiologist who will be performing the diagnosis on these examinations. Thank you very much.